There we go. Hello and welcome to the AIMS Rehab webinar, which is a follow-up session to the one we held with Sri and Helen on the 17th of April. And in this second session, Helen and Sri will be looking into some of the, in more detail, some of the questions that was raised during the first session. And I'm sure there will also be opportunities to answer a few questions to them both. So just again, my name is Fatima. Behind the scenes, we've got Connor. But before we get into the meat of the session, let's just do a couple of housekeeping. So if my slide allows me, bear with me. There we go. So this is a live event, as you know, and you are on mute unless you are a designated speaker. The webinar will be recorded and uploaded to our website, and they'll also be accessible to our members on our Knowledge Hub as well. So if you have a colleague who's interested in, I guess, in listening to this session but weren't able to, you can forward them the link, and I'll be sure to share that on Twitter as well as through our thank you email after this session. If you have any questions, please use the chat function to ask the questions. The chat function is a little, if you hover your cursor, it's a little Q&A box, and if you click that, you can ask questions to the speakers. Just to note that this is a free event. We are a free event open to the public as well as to our non-members. But however, if you are interested in becoming AIMS Rehab member, then please do either email us or visit our website. There's loads of benefits to becoming one of our members, and one of the huge benefits is that we will support you to improve the quality of your service, working with patient carers and staff. We also have a range of knowledge sharing events such as our webinars, as well as special interest days and annual forums, and there's lots of ways that we can support you to improve your service. So please do visit our website and do sign up. And I'd encourage all NHS trusts as well as independent service providers to think about becoming members. So without further ado, please let me hand you over to our speakers, Helen and Sri.
Thanks very much indeed, Fatima, and welcome again, everyone. Thanks very much for joining the webinar. As Fatima says, we're going to pick up on some of the questions that people sent in that we didn't have time to talk about last time, and we'll also pick up on any that you send in during the course of the next hour. We thought we'd just start with revisiting the topic of how to keep staff morale going during these weird and strange times that we're all working within. Both Sri and I will talk to this, but I guess what I thought I would do is to describe to you how we're managing this in my particular community service. I work across two different bits of the community rehab service, both the community rehab team and into two community rehab units. And I guess the big thing that has been most important throughout the last few weeks has been communication. So we have found ourselves, we've evolved to have a lot more communication than usual. We always did communicate well, but it was much more kind of boundaried, I think, really. We would have obviously regular team meetings and then regular sessions when I would be doing clinical work in those services, and we're still doing that, but we're also having a lot more sort of free-flowing communication through WhatsApp and telephone calls, making sure that staff feel working from home, obviously a part of that, is really important. We've been checking in with each other on a daily basis, so our WhatsApp starts sort of, getting active at around 8:30 in the morning, with people saying hello and checking in that everybody's all right, that none of us have got any symptoms. Also other practical issues come up, to do with IT problems or anything else that people might need support with. And that, I think, has been the key component, really, that we've all been supporting each other. And as you know, difficult things have happened. Obviously, patients have become unwell. Some patients have died. It's really lovely to see that kind of morale boosting support network absolutely there, and people very responsive and able to send in support and comments and suggestions to each other. So in a way, it's a sort of microcosm of what we're seeing in society, with this sort of increasing sense of community that's happening. That's happening, I think, very strongly within all of our teams. I'm going to let Sri add to that.
Yeah, thanks, Helen. So Sri Kalidindi, I'm a consultant psychiatrist at SLAM, for those of you who don't know me. And also, so I have a community rehab team there in Croydon clinically, and then my other role is with Getting It Right First Time with NHS England and Improvement. So I think in terms of what Helen has said, lots of those functions as well within the team, trying to just manage some of the anxiety, and we've had about 5 deaths of our service users. They tend to be those people who are much older with comorbidities and so on. They are people who we've known for many years often, and so just kind of trying to support the team through that we've been really kind of quite mindful about how we might do that. We've started daily mindfulness sessions at the beginning of our handover, with our psychologist leading that, and people have found that incredibly helpful. And then they're also able to use that sort of mindfulness way of being and thinking at other points in their day, just to kind of try and keep on top of things and centre themselves. And then I guess one of the other things is just having very open. We have a staff support group as well. Once a fortnight, occasionally it increases if we've had other things that have happened that people want a bit more support. And we've discussed things like the challenges of working at home, with kids and pets and all that other stuff that goes on when you're trying to work from home, and all sorts of examples of people having to share space, and all sort of distractions that go with that, and being stuck at home. So and feeling disconnected. So although we've had a rota of people coming in, there are some people who just have to shield, so they have to work from home permanently. So we've certainly had to think with them about how we can make sure they feel connected as well. And and like Helen has said as well, we've been much more open actually with sharing some of those. We're always pretty good, but I think that sort of stepped up to a different level of sharing some of our sort of anxieties and some of the challenges that we have, perhaps with some of our home situations, so that people can understand better and be more empathic and supportive in helpful ways. And then I guess just thinking up at a trust level, we've got a layer of support, and I'm sure all of you are looking at what you've got locally, and I would encourage you to sort of support your teams to tap in, and I guess any of the people who are leaders in their teams, I mean everyone is, but in sort of the more kind of formal positions as well, of showing that they're using that support and how it's helping them as well. And also there are the national helplines, NHSE helpline for all staff. There's the PHP, Practitioners Health Programme, for doctors, but they'll take other people as well if they can. And what I'll do is, I'm sure you've got them, but when we send out links after this webinar, I'll include those as well, so they're to hand. So I think that's all I've got to say really on that matter for now.
Okay, great. Thanks very much, Sri. So just moving on now, thinking about some of the questions that we didn't get to discuss in much depth last time. One of the things that has been coming up a lot recently is what comprises essential work. This, I think, is particularly kind of relevant to those of us working in the community and thinking about visiting clients in supported accommodation or in their own homes. Obviously, when the lockdown started, essential work was really limited to people who needed a home visit to, for example, have a blood test or to receive their depot medication. And I think what we're beginning to have to think about is, how we might change the way in which we work to be able to keep in touch with clients and deliver the support, treatment and interventions that we would normally deliver, either through different mediums or through face-to-face contact. How do we balance that? I don't know about you, but I'm really very frustrated by not being able to visit and do home visits and see clients in the usual way. We're doing our reviews through teleconferences, mainly because we haven't been able to get our video conferencing to work very efficiently, and it's quite difficult to set up video conferencing with lots of different supported accommodation providers. So we've ended up falling back always on various ways of doing telephone calls on speakerphones or through teleconferencing, and none of it's ideal. What we've been doing recently is to have a member of our team, usually one of the nurses, but the care coordinator, going to the supported accommodation, using social distancing, being able to have them and the client and their key worker from the supported accommodation in one room, and then me on the telephone. And so we try and have a four-way conversation, which is kind of similar to usual, except obviously I'm not in the same room. For some people, to be honest, it's better. For some people, they obviously find it easier to have a conversation through the telephone. So there's some learning there. For some people, it's less sort of intimidating or demanding than a face-to-face conversation. But that is the exception. Mostly, I'm finding it really difficult actually to have the kind of conversation that we'd normally have with somebody face to face. To try and do that through telephone is just not really adequate. Obviously you're not getting all the social cues, and you're not being able to make kind of direct visual observations of what's going on in the room, but also it tends to make the conversation much more directed and less free-flowing than usual. So we're beginning to think, well, can we loosen things up? Is it going to be possible for us to be able to kind of go back to more like our usual approach? Now, obviously, government guidance and indeed local trust guidance is not saying that we should yet. But as people are beginning to talk about how we come out of lockdown, obviously we need to think about this. I suppose one thing that is potentially going to help is if we are able to access regular testing, and there's talk about having weekly testing of NHS staff. That would certainly help, because it would at least give us sort of fairly regular information about whether we are representing any risk to clients when we do home visits. And obviously, if we had a positive test, we certainly wouldn't be doing any kind of home visiting. But I think we also have to think about, the building, whether or not there is a space that people can be in together for a meeting that gives you enough social distance, whether or not staff and indeed clients should be offered and should be wearing masks in order to have those sorts of conversations, or whether that in itself would introduce another layer of bizarreness that may not be helpful when what you're really trying to do is to have as normal a conversation as possible. So we haven't reached any conclusions about this yet, but we're beginning to think, how could we loosen things up a little bit in the future, and hopefully it will be in the relatively near future that we can. Obviously, for urgent assessments, we have been having to do those, and staff will again try and obviously follow social distancing, but they will also be wearing PPE as necessary if they need to, in line with all the published guidance. But it does introduce a very strange layer of a barrier between you and the client, to be trying to talk to them through a mask, perhaps wearing gloves. It's a very different experience to our usual attempts to build rapport. So interested in other people's experiences of that, and where the thinking is going from any of you who are working in the community, whether or not you're also having these kinds of conversations. I'll hand over to Sri for her comments on that topic about what constitutes essential work.
Yeah, I mean, I think what's happened, Helen, is as we've all, calmed down in terms of understanding how to reorganise services, we have definitely been increasing the work back to, what we would normally be doing as a service. So the CPAs, we're certainly doing those. And it is different, but we're managing. I'm finding that they're tending to be shorter, actually, because it's sort of and one of the conversations we've been having locally is just how we sit with people who are not always wanting to, or not very communicative at times, just to be able to sit with them online. You know, in person it's sometimes easier just to sit with that quiet until people can speak and so on, and it often feels like you're being a bit more businesslike when you're online, so we're trying to kind of readjust how we think about the online meetings to give people enough space and not rush through. I think some of the other work that has been returning to normal is our supporting the care home staff more than we had been doing while we were trying to get our own house in order. So again, going back to supporting them with psychology input as needed, in turn to help them to support our service users. I mean, people did ask last time, and I hope they received the information about how we've moved to 12 weekly clozapine, for example, which then does free up other time, you know, we don't have to have so much face-to-face, which has all sorts of implications, not least in terms of making sure we've got enough PPE. So I think that's really it around the essential care. We're trying to get back, you know, to do as much as we possibly can. And the other bit is, and Helen, you talked about it, is how we're just more creative with our care home staff and our sort of supported living staff around what they can provide in-house in terms of rehab and activities. And so your psychologist sent something out which I thought was helpful, but there's lots of stuff out there, you know, from Joe Wicks doing his exercise, you know, the body coach, to different, you know, kind of cooking classes, to all sorts of other activities that can be done, and they can be done in a sort of socially distancing way. So I think that's it's very interesting having to rethink it all, and also I think part of that essential care, returning to essential care, has to be our support of the staff in those settings as well, who are also feeling quite anxious and not understanding necessarily how to support people. One of the other questions that came up was around how do you support somebody who's non-cooperative, you know, our service users in the community who don't really get how the social distancing, or even if they understand at some level, aren't able to maintain it. And that's, I can see that's come up in the question in terms of on the inpatient side, which we did talk about last time, but in the community, that's been some of our most challenging work, is how do we support people, particularly those who've got drug and alcohol use as part of their picture, because they're going out to get their drugs and alcohol. And obviously it's very concerning. We're getting to the point where we're having conversations about trying to avoid evictions. And in 2 cases, we've had to move people to another setting where there are fewer vulnerable people. We've managed to do it in a kind of managed way, and nobody's kind of ended up being evicted onto the street. But you know, care home staff are worried for their own health and also the other vulnerable residents. There's no easy answer. I think it is just trying everything, and we have really stepped up. So, for example, one of our service users, just every day we've had phone contact, and they've been able to make some significant changes actually in terms of just going out for 2 hours a day to exercise and drink, but not to excess, so they're not coming back inebriated, in which case they can't maintain any social distance. And then setting up everything from finances to you know, the staff support, the medication, having that in the morning so that they're a little bit more sedated, you know, all sorts of things to just help whatever needs to happen for that person.
Yeah, I think that this issue about how we react and respond to people who are finding it very difficult to kind of go along with the guidance, both on social distancing and self-isolation, has been one of the themes which has run through all of our work, and it's the one that we get the most emails about from supported accommodation providers, and that we, you know, proactively trying to feed into as much as we possibly can. Obviously, it's hugely distressing if somebody can't follow the guidance, and you're worried about their safety, you're worried about them presenting a risk to other people through potential contagion. Obviously, it's even worse if, you know, the person should be in the shielding category, or indeed if they're showing any symptoms of COVID and haven't been tested. Basically, where we've got to with that is trying to do a really detailed assessment of that person's story, their particular situation, getting as much information as we can from the supported accommodation staff. Often we obviously know the supported accommodation project, but we don't always know the exact layout of the bit of the building that that person is currently in. And quite often the supported accommodation staff have already moved the person to an area where they can hopefully facilitate more self-isolation. Often they're trying to provide them with a bathroom, for example, that they can be the sole user of, where that's feasible. Obviously, it depends. Some supported accommodation services have ensuite facilities, but not all do. So those sorts of practical things are things that already the supported accommodation staff have often thought through, but if they haven't, of course, they're things that we can feed into. And it's really about trying to sort of find ways in which you can communicate to the person the importance of following the guidance. And, you know, it's absolutely understandable. We're all fed up with lockdown. Everybody wants to start getting out and getting some fresh air. And how do you communicate that and put that across to someone who may have cognitive difficulties and not really be able to understand the rationale? And also have other drivers that are taking them outside of the building, simply being kind of agitated and energetic and unable to just sort of sit still inside, or of course being driven to go outside for other reasons, like wanting to visit family or friends, or indeed to access substances. So it's understanding what the drivers are for that person, trying to find a way within the building to minimise their contact with others, and then having that conversation repeatedly in a sensitive and humane way that doesn't end up feeling as though you're just nagging the person. And I guess over the weeks that we've been having these conversations, that is really where we've all come to, is that all you can do is to put in place as many props and facilitators to help the person self-isolate as possible, and to continue to have the conversation, and of course to record that you're having the conversation. But ultimately, if somebody is kind of breaking the rules, not able to follow the guidance, it will depend on how much risk they present to themselves or others as to whether or not something more draconian has to happen. We have had one or two service users where a stiffly worded letter from the local police has really helped. One that starts off reminding them of the guidance and finishes up by sort of telling them they're potentially in breach of the law, and, you know, that there could be serious consequences. Some of our service users have actually been fined when out and about in the community because of being out and about in the community too much and being spotted by the police many times in the same day. So, you know, there are external containers that can reinforce the message as well. We haven't gone down the route of moving people to other accommodation. There has been talk about that. Our concerns about that are that, you know, it's not as though we've all got lots of empty 24-hour supported accommodation where we could move people to. And so often the alternative that's being discussed are things like hotels. And, you know, these are not going to be supported in the same way as our own supported accommodation. And so, of course, we worry about people not getting the right support for their mental health problems, even if they are then able to be in a place where they would have an ensuite bathroom. So I think it sort of comes down to reviewing that particular person's situation, obviously knowing their history, knowing their risks, and trying to make the best plan you can possibly make. And if it's possible to pull in external forces like the police as well, then of course that's really useful too. I'm just looking at the chat forum questions that are coming in. There's a comment here about the fact that we're using different medium like telephones, that sometimes that's helpful, that sometimes we're finding it easier to talk to people through a different medium than the face-to-face, and how we might be able to kind of hold on to that, perhaps when things are loosened and we go back to more of our usual practice. Well, I suppose I mean, with this particular example I was thinking of, for that particular individual, I've spent, some time having interactions that are generally satisfactory, I'm sure, for them as well as for me, where the person is really quite irritated by my very presence, and we don't get into a constructive discussion, we just go round in a loop. And so actually having the experience of a warmer conversation was lovely for me, and I hope also nicer for that person. So I would learn from that perhaps for that particular individual, we should always do our reviews like that, where he's in the room with his care coordinator and key worker and I phone in, and that may allow us to have a much better rapport. So I think we can learn and we can become more flexible about how we conduct our usual practice from this, and not just go back to doing everything in the same way. And indeed, I think we're going to have to be more flexible and do things differently and in a more mixed way than we have been. Coming on to another issue, which also picks up on one of the other one of the other questions that's coming into the chat line, is about, there's a question here about managing leave. It kind of overlaps with what we were talking about around not being able to support, people not being able to support and follow the guidance. But I think there's a sort of wider issue here, is about, we're rehabilitationists. We are used to working with people in order to facilitate their ability to live as independently as possible in the community. So our work is often about function. It's all about trying to help people gain those skills for community living, to improve their confidence so that they can be more and more autonomous. And what we're living through at the minute is a situation where we're all being basically controlled by the state. We're all being told what to do and what we can't do. And we're having to, tell people what they're allowed to do, when they're allowed to go out, in a way that we're not used to, particularly in community settings. So how do we keep a rehabilitative ethos going when the context that we're all living within is rather draconian? And I suppose that again comes down to what we talked about at the very beginning of this whole webinar, which is about the communication with staff. So of course, in order to respond to somebody whose behaviour is risky, we need to have a conversation and work out an individualised plan and approach that all the staff are aware of, so that we're providing a consistent response. We also have to remind people that although we're all living in a situation which is anxiety provoking, our job when we're at work is to be rehabilitationists. So the fact that we have more people indoors in our supported accommodation and our community rehabilitation units, in many ways has some advantages. Quite often we might be working with people to build structure and to build a routine and to have lots going on in the week. But it's often a little bit hit and miss as to how well we're able to do that, because people come and go and they'll go out and spend many hours outside the unit and not necessarily be engaged in highly constructive activities. So now we have an opportunity to do a lot more of that work with individuals, and we can do that through one-to-one, and we can do it through small group activities. We've started doing a lot more in-house activities of a kind of leisure variety, but also of ADL support, so running more cooking groups, helping people think through a more sort of systematic approach to things like doing their housework, doing their laundry, all the boring old chores that nobody ever really wants to do, that we kind of bang on about all the time. We're actually having more time with people to get them feeling more confident and skilled about those things. And we're also doing well in terms of getting more and more people able to self-medicate for the same reason. People are in the unit more, so it's easier to be able to work through a graduated self-medication program than it is when people are coming and going a lot more. So I think that's another big part of it. We've really got to hold on to what is the role of rehabilitation, and even in this weird context we're still working towards people being able to self-manage to their highest ability and to be able to move on to more independent accommodation in the future. And so we have to really kind of hold that message. I'll hand over to Sri for any further comments on that topic.
Yeah, I don't think there are any further comments really on that topic, so I don't know whether we want to move on perhaps to the next one. So One of the questions that came up last time was around end of life care. And I know that this is something that it's not something we talk about that often. Well, certainly not in my team and other teams, because we, generally we're not in a situation where we've got relatively, more people dying. So also, obviously, with COVID, we don't know who is going to become ill or when. So it really is thinking not just of people who are in the high risk set, what we would deem to be high risk, but do we have this conversation with everybody just as part of their routine care? And certainly I think that's becoming more the norm. And what we've got is some guidance and templates from the National Director of End of Life Care and Palliative Care. So I'll certainly send those out, because it gives just some framework and structure for all of us as staff to, and even supporting staff in the care homes, to start having a think about with people. It's not a very easy conversation generally, but it is one that I think is really important, because what it does is it helps people to at least have some level of control in how things might go, and it's really important for us to know what their wishes are. So we've had some training as well in our trust, because again, it's not something we're used to doing. So I would encourage you to have a look at the stuff that I'll send out if you haven't already, but also to approach your trust and see whether there's going to be any training, if there hasn't already been, for teams to really think about how you're going to roll that out. And we're just starting to incorporate it now as part of our CPA reviews, and more general reviews as well. So
yeah,
Helen, if you want to.
We've also been tackling this one. It's interesting that COVID has brought this topic up. Of course, it's a topic that we should have been thinking about anyway. Our client group often do have serious physical health comorbidities, and sadly, many of us will have experienced people having sudden severe physical health emergencies and also sudden deaths over the years. So it's not as though we should be surprised about the fact that things can get very serious very quickly for this group. So I guess COVID has just concentrated our minds on it. And what we've been doing is to, I'm sure everyone has been thinking about the people on your caseload who need shielding. But that has allowed us also to think about, well, are there other people who we need to have conversations with as well as that group about what sort of medical treatment they would like if they became very unwell with COVID? And this is a really difficult conversation to have with people. Anyway, it's also difficult if people may struggle to understand what it is that you're trying to discuss. So you have to think carefully about how you broach the topic. And it would be slightly different, of course, for different individuals. But one way we've found that's quite successful is to talk in general terms about, obviously the whole world is going through a health crisis, and some people are becoming extremely unwell and needing admission to hospital and potentially further medical interventions. And that our assumption is that this person that you would want the same. And that tends to open the conversation about whether the person does want the same and what they mean by medical intervention and how far they would want to go with medical interventions. And I think there are two reasons for really sort of making sure that we do this proactively with clients at the moment. First of all, because we can't actually predict whether or not somebody will have a very serious illness if they were to get COVID symptoms, and so we can obviously suggest that people who've got underlying physical health comorbidities are more at risk, but we still can't predict who's actually going to end up needing, for example, a ventilator. So it's good to have that conversation before you're in the position. Secondly, it's because at the time when obviously there was a huge worry about the NHS becoming overwhelmed, people did become appropriately concerned that it may be that those who had underlying physical health and mental health conditions might not be prioritised for limited ventilator space. And so we felt it was really important that we, as the clinical team, made a statement about what we think would be the appropriate thing, but we also, of course, make sure that we include the individual's views on that. So we've gone through our whole caseload of about 150 people and identified anyone where there may be any query from our perspective about whether or not such proactive medical interventions would be appropriate, and then obviously prioritise that conversation with the person. But we're gradually going through the whole caseload to make sure that there is a record in their physical healthcare plan about their views on this. Obviously, if somebody's struggling because of capacity, then you get a different conversation and a different assessment, particularly, of course, if they are saying that they want to decline medical treatment. So it leads swiftly into capacity assessment and potentially best interest assessment if the person says that they want to decline. But I do think this is a really important topic, and it's a really important thing that we do. We're advocates for people. Of course, I'm very pleased to say we haven't come across an example where anyone has been refused treatment on the basis of their mental health problems, but we feel that this was a really important kind of position really to take, and a process of advocacy that was really important for our clients to hear and for us to be able to air these really difficult discussions. Obviously, if somebody does say that they don't wish for proactive medical treatment were they to be in that situation, there then is a national process of which is held through primary care. So you alert the GP, and then they put an alert on a national system so that the local ambulance service are aware that the person has elected not for resuscitation. And of course, as I say, that can only happen if they're capacitous at the time. Shree's links to the national guidance are really important to read as well. There's another topic that somebody's raised in the chat line here about managing discharges into the community. This particular question is about when a CTO is needed. So I think sort of more broadly, we've done a lot of thinking and now got a local policy about transitions out of the inpatient setting into the community. This came up because in the midst of 2 or 3 weeks ago, when everything was sort of new and there was enormous pressure on the inpatient beds, we were under a lot of pressure to take people at short notice if we had a vacant bed. And we don't often have a vacant bed. we usually manage our referrals and our new admissions very carefully, and have continued to do that through the pandemic. But we were finding ourselves being kind of pressured to try and speed things up, or to take somebody if we had, for any reason, a vacancy. And what we've been able to think through is that you need to think about again, it's really about the person coming into a community setting, what that community setting is like, whether or not it's a communal setting, whether or not the person is going to be able to self-isolate if they needed to. So obviously someone coming out into a self-contained but supported apartment is going to be a different conversation to somebody who's coming out into a setting where everything is communally shared and there are no ensuite bathrooms. Our trust, and I think many are now doing COVID tests at the point of discharge. So if somebody has had a negative COVID test, then obviously you feel much more reassured that they're not going to be introducing infection into a communal setting. Of course, a COVID negative test is not the only thing you need to be looking at. You do need to look at whether they've got any symptoms, because COVID negative tests are not 100% guaranteed as being accurate. They're about 80%. And similarly, which ward they're coming from, and are there any other people on that ward who've got symptoms or who have tested positive. So, and then to sort of be able to think about, well, what kind of time frame do we need to bear in mind? And again, it depends on the setting that they're coming to. If somebody's coming out to a self-contained type of setting, then obviously the risks are much less. So those sorts of transition protocols have been recently drawn up, and we're feeding into that because different hypothetical scenarios don't always play out in real life as being exactly how it needs to work. So I think there isn't a quick answer. This particular question was about managing discharges into the community where a CTO is needed. Well, the CTO is sort of just operates in the usual way. Obviously discuss with the inpatient team what the conditions are if you think somebody does need to be on a CTO. And I think that sits separately to this separate issue about the way in which you manage a transition safely from the inpatient setting through into the community. Have you been doing that, Sri, in your trust, thinking about transitions out of the inpatient setting?
Oh, absolutely, we have. And obviously this new guidance has come in, so we're following that. I mean, for example, one of the nursing homes that we use, they've actually, because they've had a number of people who've died of COVID, actually, it is a nursing home with much more elderly people in it with comorbidities. So we're just not sending anybody there for now. But yes, anybody who is transferring across to the community is absolutely being tested. We're waiting to get a negative result beforehand. And that can be reassuring. And one of the other kind of linked questions that came up was around how do you balance the safety of service users and staff, and of course that goes to the wider safety as well of other people, which is linked to this. Certainly in our team, I think one of the key aspects that all of us need to understand how we would challenge if, for example, there's not enough PPE. And fortunately, I think in my trust we have had it. We've not really had too much of a problem. But you know, I've been quite clear that the staff have to have it, and service users as they come in will also use masks in our kind of communal areas of our resource centre. And we know also now from the more recent evidence that's coming through that only 40% of the transmission of COVID is with through symptomatic people anyway. So the rest of it, the other 60%, we're not going to know who's carrying COVID and who may spread it to other people. So I think that given that knowledge that we have now, it's really important. And we just can't predict, you know, who is, as we talked about earlier. We know who is going to be impacted really very severely and who isn't. So we've been quite hard-lined on that actually, and luckily it's not come to us needing to go anywhere near saying we're not going to see people, because we've just not been in that position. We've always had PPE, but I would say to people, you know, really push that upwards if that's an issue in your area and your trust, because you have to stay safe. You know, you're a very key member of keeping everything going. So, and you know, if you are not able to keep going, that has a huge impact on the workings of the team and you know, obviously the care that you can give. So I think that's you know, there is a balance, but I do think staff have to be protected.
Yeah, for sure, for sure. There's another comment here. It's a really interesting comment about has the information that being overweight increases the risk if you develop COVID symptoms, similarly smoking. Has this helped in our facilitation of people's physical health? And we did touch on this, I think, in the last webinar as well. But yes is the short answer, certainly around smoking cessation. We've had a lot more kind of fruitful discussions with people about smoking cessation. I spent also about half an hour talking to somebody yesterday about fruit and vegetable in their diet and needing to work on exercise to lose weight. These are the conversations we have all the time in care reviews, but now we have this sort of added impetus to say to people it's really important to try and work on your physical health. So it is acting as a positive lever. Obviously too early to say whether it's having a true impact in terms of a measurable outcome, but just anecdotally I'm certainly finding it that it's easier to have the conversation, or to rather to it feels as though people are more receptive of the conversation. It's not a kind of in one ear out of the other in the way that it might usually be. So I think it is being people are listening to what's on the news, and they're tuning in when we bring these things up in a way that perhaps they weren't always. There's another question here about shielding as well. The experience of patients who need shielding. This obviously overlaps a bit with what we were talking about earlier around the difficulty some people have in following the guidance on social distancing and self-isolation. In terms of shielding, obviously having knowledge about which of your clients do meet shielding criteria, whether or not they've had a letter from their GP to formally identify them as such. It's really important that we're on top of that. And you also have to think about the ways in which you can support them to shield, and to try and reinforce the message about minimising their contact with others and not going out. And so of course we then have to think about the situation that person's living in, and whether or not they need somebody to do their shopping, whether they need home visits to have blood tests if they're on clozapine, or home visits for a depot if they're on a depot. So again, trying to kind of break down all the different parts of that person's treatment that are going to be affected by them not being able to go out. That's what shielding means in terms of a practical application in our community services. However, it's been really important also to not sort of necessarily throw all of your limited resources in the community team at doing home visits for everyone who's in the shielding category if that person just isn't going to follow the guidance. So, why would we kind of make not only a sort of big effort, but also be putting potentially staff at risk of doing a home visit if the person is also going out? So if they're not able to follow the guidance, sometimes we're making a balanced judgment about whether or not it is okay for them to, for example, go to the clozapine clinic or come somewhere else for their depot. On the whole, we're trying to do home visits for all of those people, but there are exceptions where somebody just isn't following the guidance, and then it seems sort of illogical to be doing a home visit when actually they're visiting the community a lot anyway. Sri, anything else you'd like to add about shielding or physical health?
I think we talked about it last time. It is a real opportunity. People are keener, perhaps, to stop smoking, both in terms of the worry, should they get COVID, in terms of their risk, but also the having to go out, and people who are not wanting to go out because they understand the risk. It's another kind of motivation, so they don't have to keep popping out for their tobacco or their cigarettes. And it's interesting, I think, we're seeing some of the return of back to seeing primary care, and also even A&E usage for other non-COVID conditions. So certainly I think that's started as well a little bit, more outpatient appointments that we're obviously mostly online still, not face-to-face, but that those have started to resume. So we're just making sure that our staff in the care homes can support that as it's restarting for some of our service users. I guess one of the things that I'm conscious of again is just that kind of whole advocacy around physical health, because again, they are so inundated. If somebody isn't really engaging, or they need a little bit more support to access that kind of physical health, secondary care, and primary care, that they kind of go to the bottom of the list. So we have to keep on top of that. And just one example, somebody who wasn't prioritised, even though they'd had a recent MI, and we had to have a conversation, with secondary mental health staff and get them back on, and get them in to have their echo and so on and so forth. So I guess just to be a little bit aware, because I think that's heightened now, than perhaps it previously was, just because of the resource issue right now.
Yeah, and I mean, obviously it's an issue always. We often are having to push for people to get appropriate follow-up for physical health abnormalities. So but I agree, it feels that there are more barriers to push through at the moment for obvious reasons, but we have to continue and not sort of think, oh, well, this will all come right. It probably won't. We probably do need to just be pushing and keeping the GP up to speed as well with what we're doing so that we're not duplicating efforts. Okay. Well, I've come to the end of the things that we hadn't managed to talk about at the last webinar, and I think we have covered the questions that have come in through the chat line. So I think we can probably end a little bit early, unless anyone wants to send a comment in immediately, in which case we will certainly answer it. But otherwise, just to say thanks ever so much for tuning in, and keep safe and keep rehabbing.
Yeah, keep up the good work, everyone, and stay safe.
Brilliant. Thank you very much. Thank you, Sri. Thank you, Helen. Just note that we do have a couple more webinars coming up in the next couple of weeks. And if you are interested in attending them, please do get in touch with us. The next one's on Monday the 18th, and that's going to be held by Dr. Sabina Burza, as well as Dr. Raj Mohan. And we also have a care engagement and support webinar that's going to be held on Monday the 1st of June. So if you're interested, please do contact us. Again, we also have a reflective forum, and that's just open to our members at the moment. But if you're interested in attending one of those sessions, please do again email us, and this could be a good way for you to actually connect with peers and just provide that informal support to each other. And we also have a useful resource bank on our website, where we have, I guess, regularly updating the guidelines that's currently being published by NHS England and Improvement. We also have a COVID-19 discussion forum on our Knowledge Hub. Again, that's open to members, and if you're interested in a membership and accessing this, then please do contact us. But apart from that, thank you so much, and we hope to welcome you again soon. Take care, bye.